Hello, I am Gintare Malisauskaite. I work in University of Ghent. I'm also part of the ASCRU project team. I normally work with Aldena, Jules, and a few more other individuals from Ghent, and I'll try to share my screen with the presentation. So let's hope this works.
Yes, we can see it. Thank you.
Great. So I'd like to talk today about some of our findings from one of the risk factors project, smaller projects, and it's about how alcohol consumption frequency impacts uptake of long-term care use in people over 65 years old. As I mentioned, I'm part of this research team, and if you have any questions that you'd like to discuss with me in further more detail, here's my email address. So first of all, our aim was to look into how previous alcohol consumption frequency is related to the uptake and start of using long-term care, both formal, which is professionally provided by institutions or individuals, or informal, which is provided by friends or family members among people who are 65 plus. So we normally anticipate that the relationship between alcohol and long-term care could be fairly complex and nuanced and is going both directions. Especially once we take into account social preferences and social attitudes. The currently existing literature that touches on this subject is very scarce, mainly outdated, not UK focused, and doesn't look into all types of care like informal care. There is one study that is quite similar to what we are asking in this research, and it's about Canadians over 50 years old, and they found that moderate drinking actually is related with lower need of long-term care in old age. More of the literature is dedicated to how alcohol impacting other health conditions such as dementia and heart conditions, and findings are mainly mostly mixed, and there's some indication of there being a protective effect of alcohol towards some of these conditions. So one of the things that we would like to draw your attention to is that we find this a fairly complex issue. So alcohol is related with multiple other factors before we arrive to long-term care use. So health would impact underlying need for care, which would then impact perceived need for care, which are different and can go both directions. Alcohol use would then impact health, and health might impact how much alcohol is being used in reverse. Alcohol would also impact underlying care need. This is where preferences, behavior, and social attitudes impact all of these factors. So they would, from day-to-day behavior, would impact how what would be overall health of the person. And then health could also in reverse impact behavior and social attitudes. Behavior and social attitudes would impact alcohol use, and that could also come in reverse, would also impact perceived need. So antisocial behavior could lead to less care being offered, either formally or informally. And so overall, it's a quite big puzzle to solve out in order to arrive to an answer. So we have a few main hypotheses. That first of all, we believe that frequent drinking should be related to increase in long-term care use in the future. Then secondly, that most of this effect would be primarily related to a health channel, that alcohol would impact health, and that would lead to a higher need of long-term care in the later in life. However, we also anticipate that there could be other effects, and that care seeking and care providing may be negatively impacted by more frequent drinking, and that these effects may vary slightly depending if it's formal or informal care. So the way we approached this question was we used an English longitudinal study of aging, waves 2 to 8, for the population that is 65 plus. We ran different regressions by gender, and pulling them together, we tried to exclude individuals in the previous wave that were using care so that we capture the start of using care. Our main dependent variables were use of formal and informal care, both binaries, either using or not using, and main variable of interest was alcohol consumption frequency in the past 12 months. This is a categorical variable, and it's lagged, and we use it from information from previous wave so that we find out what is effect of alcohol into the future receipt of care. This categorical variable has 3 categories, which is non and infrequent use of alcohol, which is our base category, then regular use, which is 1 to 4 times a week, and frequent from 5 days a week to every day. Then, since accounting for the complexity of the relationship, we use polygenic score that predicts daily alcohol intake obtained from ELSA polygenic scores dataset. We have trialed multiple other instrumental variables, including spatial lags, alcohol-related hospital admissions, alcohol-related mortality, number of pubs, and so on, but their results did not seem as trustworthy compared to the polygenic score. We control for a list of different variables, which the base specification, this includes educational qualifications, ethnicity, age, number of female children, home ownership, ability to rely on friends and family members. Then also additional specifications include behavioral information, mental health, marital indicators, health indicators, and all of the specifications include wave indicators. We ran 2 different types of models. One of them is PERBIT, which does not account for the complexity of alcohol relationship with long-term care, and ePERBIT, where we use the instrumental variable, trying to distill the relationship into what we believe to be the closer to the truth result. So that there are 2 main samples. For both males and females, it's over 6,000 observations, and formal care in uptake amongst males is 2.1% and 4.3% amongst females, and informal care use for males is 7.5% and 11.3% for females. So for the uninstrumented results, without accounting for the complexity of the relationship between alcohol and long-term care, we find that for both formal and informal care, there's a negative relationship between alcohol use and long-term care use, which seems fairly counterintuitive and would make you ask, so should we drink more in order to need less care in older age? So for that, we went with an instrumental, a variable approach, accounting for the complexity of the relationship, and looking if we can find a more precise answer to this question. So what we find is that for formal care in the pooled sample, we're looking at males and females together, frequent alcohol consumption is related to statistically significant increase in formal care use. However, we do not find the statistical significance for male or female samples separately, and we also do not find the statistical significance for regular alcohol consumption. For informal care, we do not find any statistically significant relationships. However, most of the signs of the coefficients tend to be negative, potentially indicating lower use of care. We believe that polygenic score is actually an adequate instrument for alcohol use because we believe it predicts alcohol use well and would not be related to formal or informal care use directly. For sensitivity analyses, we ran a lot of different specifications, including different variables and different models with different instruments. And overall, we found that from those that are closest to what we're doing here, the results did not vary too much, and we found our results robust. So overall, we find that there is a difference in uninstrumented and instrumented results that indeed suggest alcohol variable is prone to endogeneity, which means that there indeed is a complex relationship between alcohol, health, and long-term care use. Our results mainly indicate that when we account for this complexity, we find a statistically significant increase in need for formal care use in older age in the pooled sample, but no other statistically significant relationships. Most of these relationships for formal care tend to have a positive sign and a negative sign for informal care. So overall, our main conclusion is that there is still an incentive to invest in policies relating to reducing alcohol use frequency in general population, because it's likely to end up overall, the way we interpret this result is that because of alcohol use, it has an impact on relationships and ability to use long-term care. So if informal relationships suffer and suffer negative consequences due to alcohol use, then it is more likely to fall on informal care to look after people with increased need due to alcohol consumption. So any policy interest in reducing alcohol use frequency would result in potentially better relationships between family members and more of long-term care being taken up by informal relationships rather than falling on formal care provision. So we believe that instrumenting allows us to isolate the effect of alcohol use on long-term care use through the health channel. However, there are possible other directions of how alcohol use might impact long-term care use. So through the health channel, we anticipate overall the positive effects, so alcohol use increasing the overall need for long-term care, while through other channels such as self-selection into drinking, where higher consumption of alcohol might also be correlated with lower care seeking, or chronic health conditions where it simply reduces the appeal of alcohol and results in lower consumption and lower frequency of consuming it, which both have a downwards effect, reducing the alcohol consumption and overall reducing long-term care use. We believe that effect on informal care signals damage the relationships with family and friends, leaving the burden to be picked up by formal care, and preferences and premature mortality and other unobservable factors may also be generating downwards bias, which is resulting in this statistically insignificant result. So overall, the one finding where we find the statistically significant positive effect towards formal long-term care use, we take it as indicator that it is still potentially underestimated given all the rest of the information. Yes, so I probably rushed through this a little bit too much, but if you would like to ask any questions, I'd be happy to
That's
try
great.
answer them.
Thank you very much. That was a really interesting discussion. Can I ask anybody if they have any questions to please raise their hands within Zoom or otherwise, just to unmute yourself and let me know that you have something that you'd like to ask. If there aren't any questions in the chat, sorry, did somebody say something? I think not. I did have a question about, I suppose, about the data that you have access to and the ability to differentiate between different types of drinking patterns. So I think you have the frequency with which people drink and measure of volume. But I was wondering if it was possible to pick up, for example, binge drinking on certain days or a more even pattern of drinking.
So it is slightly limited by the data we have. Indeed, ELSA has some information about both binge drinking and types of alcohol drank, such as beer, wine, spirits, etc. However, then the number of observations that we can use is already reduced. So this is why we decided to go with self-reported alcohol frequency variable and indicator. Which is basically one of the variables that has largest number of observations, and overall checking through other possible variables that we could use, we did not find significantly different results. So we thought that going with this variable is actually justified.
I think that makes sense. So Peter has a question.
Yeah, two questions really. One is, I don't know whether you monitored or looked at where people are getting their alcohol from currently, whether it be pubs or supermarkets. And secondly, is there any link with regard to diet and alcohol with regard to the ill health issues?
So we do not have information, ELSA does not provide information where alcohol was obtained from. We did try some of the estimations where we used nationally available data on number of pubs nationally, and we tried to use that as an instrumental variable. We did not really find results that would look convincing. So we cannot really control for that with the data that we have. And then in terms of diet and health, so alcohol definitely seems to have an effect on health, but we did not focus on it specifically as we were trying to distill the relationship between alcohol and long-term care. And diet, I think in the early estimations of these models, we had this as one of the variables, but actually eventually we dropped it, as this is also related to the number of observations we can have in the end of the estimation. And I think this was reducing.
Okay, thank you.
Sorry if I can't answer it a bit more with more detail.
No, that's fine, thanks.
Thank you. Any other questions? If not, I suppose I have one further question, or rather comment, regarding the finding of reduced service utilization with increased drinking. And I was just speculating as to what the mechanisms might be, and thinking, I suppose, in terms of the possibility of reduced probability of help seeking through potentially links with depression, or alternatively, for example, unpaid carers being less willing to take on additional caring tasks for people who have greater problems with drinking. I don't suppose that that's something that we will be able to scrutinize using the data that's available in the survey.
Well, we cannot scrutinize this, but this is part of the complexity of the relationship that we had in mind. And this, when I was discussing the model that we had in mind, how alcohol impacts health and health impacts alcohol use, and then social behavior and preferences, all of it also impacts all of these factors. So this is where it would also come into play potential mental health. We actually control for mental health because this was one of the potential thoughts we thought could impact how things work. We don't control for mental health in all of the specifications, but in some we do, just to see what's the overall effect. The overall effect doesn't really change that much. So in terms of, sorry, which part of the question I'm not answering? I think there was more that you mentioned.
So sorry, yes, it was just two potential reasons why
depression,
care utilization may be less, and one may be unpaid carers being less willing to provide care for those with increased levels of drinking.
So this is also something that we had in mind, and this is why we're discussing the possibility of worse relationships with informal carers due to alcohol use, and this is why we anticipate that it could fall on formal care, this care provision, mainly because it could be less pleasant or easy to look after someone who has an alcohol use issue, and maybe it's easier or more pleasant to help someone who feels that they're also not ruining their own health or something along those lines. And I think this is part of the explanation of the result that we're observing, that we did not find a statistically significant result with informal care, but all of the coefficients are of negative sign, indicating potentially lower use of informal care. And in previous regressions that were uninstrumented, both formal and informal care use is lower, so is lower due to alcohol use. So in the end, it seems that we can't. This would probably be a separate research paper trying to look into specifically into the relationship with why there could be a reduction of informal care due to alcohol use. But from what we can sort of speculate at this point, it could be just due to worse relationships with potential informal carers.